Thank you very much, Professor Ahmad. And I really need to appreciate you and your team for able to conduct this continuously. And we have crossed first anniversary, and we are heading towards maybe like second or third year. I myself had the opportunity to present the minimally invasive treatment in BPH last time. But believe me, this is such a very evolving topic, and we have so much of newer energy sources coming in the market. Lot of research happening, good amount of healthy competition among the pharmacy people that derives the quality of the care for men suffering from lower urinary tract symptoms. I will discuss predominantly four energy sources. I mean, we can discuss maybe eight, if not nine energy sources which are evolving as minimally invasive treatments. But there is a small possibility some energy sources may fall apart and may not stand the test of time, as they say. But these four have got good track of good amount of investigations, randomized studies, publications, and also various scientific basis to that, of which three are expected to give a permanent or at least long-term outcome, and one of them is like a temporary prostatic stent. So we will go ahead with UroLift. So everybody can see the slides, isn't it?
Yes, they're clearly visible. Thank you.
Thank you. So UroLift of everything is very close to my heart because I'm one of the proctor for UroLift. I do a lot of workshops, especially in Birmingham Treatment Center. We do workshops almost every second month. People visit from various countries. Not only the surgeons, we also have people like urology nurses or managers who are quite interested in this procedure, and we have trained, and I'm very proud to say, at least 50 to 60 consultants who are doing UroLift now quite regularly. Apart from workshops in the urology department in Birmingham, I also visit various countries like, for example, India, Singapore, and Middle East countries, and also the European countries like France, where we train the surgeons. Possibly the next stop is Pakistan, Professor, whenever the time and date permits.
Absolutely. It'll be honored to have you anytime of your choice.
Thank you. Thank you very much. So let's go through the basics and some evidence behind this energy source. UroLift system, how we are going to select the patient and how we need to screen the patients for this, and what are all the components of it, and how are we going to deploy the UroLift equipment, what is the anesthesia needed, and how we will plan the procedure. This is the outline of my presentation. UroLift is indicated for men suffering from benign prostatic hyperplasia. The minimum age is 50, and there is no real maximum age, but guidelines wise, because of the available of data, they say 80 years may be an ideal one. But I have operated men up to 92. The youngest men we operated were in the region of 43 or 45 years. But ideally, from the evidence point of view, the minimum age is 50. Regarding the size of the prostate, indication wise, there is no real lower limit. We can do up to 100 cc's. I've done few patients marginally above 100, like 105, 104 cc's, as long as the prostatic anatomy is permissible. But if you go by guidelines, the maximum size for the EAU guidelines is 80 cc, and for NICE guidelines is 70 cc. If you have a prostate gland size from 40 cc to say 70 or 80, the outcome is very good. There are only two things which will make the UroLift outcome excellent. The first thing is appropriate patient selection, and second thing is excellent technique. Technique wise, I will say the learning curve in the region of 15 to 20 patients, and then you can do even the complex UroLifts like median lobe surgery or 4D technique for the high bladder neck. But selection of patients are very important. Sometimes you may have a patient, say 80-year-old, prostate 100 cc, not very suitable for other procedures. UroLift can be done completely under local anesthesia with just like lignocaine jelly alone. There is no need for even an IV line. There is no need for sedation. There is no need for nitrous. So this is a very attractive procedure for elderly men who are not suitable for, say, regional anesthesia or for general anesthesia. So if we extend the indications and try to do patients with large prostates, obviously the outcome will be a little bit suboptimal. But somebody of 80-year-old who has to lead the rest of the life with a catheter, he may be quite happy to get rid of the catheter. He is not expecting to like what they say, like pee like a horse. All he wants is a very decent, good quality life without catheter. He don't mind a little bit of poor flow. So this group of patients, we can say we can do extended indications and UroLift has a role to play. And this is our aim. The video shows
invasive
everything.
technology.
So as you can see that the animation shows where the prostate is located, and we are going through the urethra, negotiating the bladder neck or the bulbar urethra or the two main areas we need to concentrate. As you can see from here, it is a normal cystoscope 20 French, which is much smaller than the TURP cystoscope. The UroLift should be positioned appropriately inside the bladder, and as you come out you need to give at least 1.5 centimeter from the bladder neck. Otherwise there is a possibility that the needle may enter the bladder neck and cause implantation into the bladder neck. Any UroLift implanted in the bladder neck area or in continuous touch with the urine in the bladder, we need to remove the implant, because the implants in constant touch with the urine can cause incrustation. While as long as the implants are in the prostatic urethra, they will come in contact with urine say 6 times or 8 times in a day, so they are quite safe. As you are seeing, we need to apply the first pair of the proximal implants, and then as you come back you can schedule or plan the implants giving enough gap, and this bulge in the tissue between the implants will get apoptosed in 12 months time. If you or happen to do a flexible cystoscopy, say for example patient is on follow-up for TCC of the bladder, those patients, when you do a flexible cystoscopy in 12 months time, you can see that this anatomy has become a much more opened up cavity. Obviously the cavity attained stays easily for 5 to 7 years. We have got evidence for that, and now as we wait longer we may get more evidences on long-term follow-up. So patients who are on watchful waiting or on long waiting list for TURP, patients on medical therapy but not happy with the medicines, say absence of ejaculation due to tamsulosin or absence of libido due to finasteride, those are all the patients very suitable for UroLift. And when you are taking the patients who are already waiting for UroLift TURP surgery, just make sure that patient's anatomy is conclusive for us. As I said, guidelines wise, AUA guidelines, EAU guidelines and NICE guidelines support the UroLift implementation. This is one of the very important slide. This is the healthy bladder mucosa, as you all aware of, and this is the patient where there are some trabeculations due to the hard working of the bladder against the obstructing prostate, and here the patient obviously developed trabeculations and saculations. This should not happen. This is like equivalence of organ confined malignancy which has got metastasized. As an oncology surgeon, especially Professor Hamad, if you see an organ confined malignancy, whether it's a bladder cancer, prostate cancer or renal cancer, we need to treat the cancer and we need to make the patient cancer free. We fail in our treatment if we allow a neighboring organ getting affected, like for example lungs or distal metastasis because of the cancer. So how can we allow bladder to undergo the impact of the prostate? So this is where the pre-font or upfront treatment comes into play. When you are going to have an upfront treatment protecting the bladder from all the secondary effects, that upfront treatment should be good enough. It should be a simple one, it should have less side effects, and it should be easily deliverable. All these boxes are nicely ticked by the UroLift implants. So patient selection is very important. As I said, we need to make sure that patient's prostate size not crossing 100 cc. And as I said, these are the main three group of patients with which we will select the patients for surgery. And you may be having these patients already in your practice, and please perform IPS score, get the quality of life, make sure they have a symptomatic disease, and the basic parameters are very important in the follow-up also. This is our gold standard lift study. As you can see in the lift study, there is a rapid decrease in the IPS score, which shows good improvement of symptoms within the first month. And the blue line is my cohort of patients, and they also had very good improvement quite quickly. And the results are quite durable for very long term. Lift study now has this graph shows 5 years, but now we have the 7-year data. We have real world study where the patients were included not from any standard studies, and BPH6 studies and multi-center studies and Australian studies. All the studies shows good improvement in quality of life and good improvement in the IPS score. In long run, they have done the dog or canine experiments where they have seen that this implant produces a good amount of obstruction, resulting in apoptosis and opening of the cavity, even extending up to 12 months post surgery. So patient selection, it's better to have a flexible cystoscopy so that you are aware of presence of the median lobe or intraprostatic extension or intravesical prostatic extension. There are various names by which the median lobe can be called. The intraprostatic extension, as long as it is less than 1 centimeter, it is doable with UroLift. So the best practice is to document the intravesical extension, IPS scoring, and quality of life. Say for example, this patient, there is a good documentation of the obstructing lateral lobes, and there is no much median lobe in this view. But once the patient had this J maneuver, we can appreciate the presence of the median lobe. This median lobe needs appropriate treatment, and since it is less than 1 centimeter from the bladder neck, we can perform a UroLift mid-lift technique. Now, this length has to be measured, and that needs to be appropriately documented. Lot of times a surgeon who is doing the UroLift procedure may not be in a position to do this flexible cystoscopy, so the colleagues or the junior doctors or the referring doctors performing these procedures should document these things quite clearly. So UroLift consists of 3 parts. This is the urethral end, which is made up of stainless steel. It's 8 millimeter in length, and we got a long suture which is made up of pit suture, just like the pit suture which you use in your open surgeries. And then we have the capsular tab, which is made up of nitinol. The total length of the capsular tab is 13 millimeter. These implants are MRI conditional, which means patient can have MRI. Only the small area of few millimeters where the implants are there, especially the nitinol tab, the MRI may not pick any peripheral zone lesions. But if the MRI sequence is appropriately tailored, there won't be any artifact due to the metal. And we have this implementation device which has got like 4 steps. The first step is releasing the safety lock. The second step is the blue switch. The third step is blue and gray switch at same time, and fourth one is the release of the implant. It's a very straightforward procedure which you can appreciate in this video. So as you can see, as a first step, we will unlock the safety lock, and then once we press the blue needle, you'll get the needle get nicely deployed, and then once you press the blue and gray, the needle get unsheathed and the implant is getting deployed into the prostate. And the fourth switch, the urethral release, will cut the suture and it will deploy the UroLift into the patient's prostate. We can appreciate this by using some videos which I'm going to show. So our main aim is to deploy the UroLift in the anterior 1/3 to create an anterior channel. There is no need to deploy in the middle or the lower 1/3 because of the neurovascular bundle. It creates a wonderful anterior channel which is more than enough for patient to pass urine. And we do the proximal implants first, just like TURP, because it will improve the water flow or irrigation flow, and then we'll do the distal implants, and if necessary we can do the middle zone implants. Sometimes patients may need 2 implants on one side and 3 on the other side, and sometimes there will be some extra nodules or the median lobe which needs median lobe separate implants. The main maneuvers which you need to be aware of is we need to make sure that the employer before deploying have this cystoscopic view of the white line, and everything is box standard deployment. This video will be very useful, and this picture shows the white line in the UroLift implant. We need to make sure that the implant is appropriately positioned. That's the most important one. This video shows how the implant is done on the lateral lobe. The surgeon has come like 1.5 centimeter from the bladder neck, and he will give a compression maximum 20 degrees. There is no need to compress more than that. And then you can see that the safety lock is released, and then once the surgeon presses the blue switch here, you can see that the needle is deployed. It's a gray color needle, and then when he presses both blue and gray, the suture, you can see the blue one, and then he needs to move forward so that you can see the white line there in a second. You can appreciate now. And once you get the white line, you can release the fourth switch in the back that releases the implant, and then the surgeon can get inside the bladder and the implantation is complete. And I will show you the post view also. So Veru can be used as a landmark for the distal implants implantation, and here we are doing the distal implants where we need to come back, and bleeding is like an enemy for appropriate deployment, but with irrigation we can manage. Make sure that you are not too much away or far away outside. This patient had the proximal implant already done, so from the Veru, just make sure the Veru is disappearing in your eyes, and you are doing again the anterior 1/3 of the implant, again at 20-degree deflection or the angulation, and the safety lock, and blue and gray, and release. These steps will go just in 1 second. Even though I'm explaining it in detail, you can see even the white line nicely came, and that opens up the distal gland, and we need to repeat it on the opposite side also. Here you can see that the median lobe is getting treated. For median lobe, we need to again make sure that we are pressing the median lobe against one of the sides. As you know, the median lobe has got left and right groove. Select the groove which is more deep so that you can use that groove and use that as an option to nicely press the median lobe on one side. Initially, our hands will be high, and once the median lobe is in correct position, the hands will be appropriately lowered, and firing will be as same as the lateral lobes. The median lobe, if appropriately treated, those patients will have the best possible outcome. We know even in TURP, compared to patients with bilateral lobes, patients with trilobe or prostate or median lobe after TURP, because of the good deobstruction of the median lobe, they will be having the best outcome. Here you can see that the surgeon has nicely compressed the median lobe, and he is able to deploy it in the same anterior plane. No way we can deploy from the top because of the neurovascular bundle as we see in the radical prostatectomy. And once the hands are in the correct position with an angle maximum 20 degree, for median lobe maybe 10 degrees enough, we can deploy, and the release is by the needle in the back side. And you can see once it is deployed, the median lobe is nicely flattened and pinned against, for example in this patient, towards the right side of the surgeon. It opens up the median lobe cavity very nicely, and sometimes patients will need even the second implant based upon the individual anatomy, and I will show you the final result. There are some tissues closer to the sphincter, but once you get in, you can see the median lobe is nicely flattened and the lateral lobes also nicely opened up. This is the open prostatic cavity. You won't get the brilliant capsule to capsule cavity like TURP, but you will get a cavity which is more than enough for the patient to pass urine comfortably. It will make patients who are not fit for TURP eligible for a procedure. It will certainly help the patients to get away from the medications. So as you can see here, when you are keeping the implant straight, and if you fire, the implant will fire 12 millimeter in front of you. That's why we have to come from the bladder neck at least 1.5 centimeter back, so that the needle firing will not happen into the bladder neck. That's a precaution. And once you form the angle, you will get the appropriate implantation in the same line. And 40 degrees is too much, 20 degree is the ideal buy. And so you should be able to create the angle before proceeding the implantation. So here you can see that angle itself makes the UroLift go up to the periprostatic one, so the capsular tab is appropriately deployed. If the angle is not there, the implant won't even reach the prostatic capsule. Similarly, if we are not 1.5 centimeter behind the bladder neck, the implant can be inappropriately deployed into the bladder neck. These are the things we need to avoid. This is the intraprostatic extension. We need to make sure that we are coming adequately behind to make sure that the implant is going only in the prostate. And regarding the anesthesia, this slide is the very old slide around 2014 when we had the L.I.F.T protocol or L.I.F.T study happening. They used diazepam, they used a catheter to place lignocaine into the bladder, but all these things seems to be unnecessary. Nowadays, my protocol is just the cold lignocaine, maybe 2 tubes 20 ml into the bladder, leave it for just 10 minutes. They can use like a gauze piece to tie the urethra so that it won't leak. If you have an access to the pinion clamp, it's not a bad choice. And then during the procedure, again use some cold lignocaine to get in so that you can create a good anesthesia. This is the usual setup. You need boxes of UroLift devices, you need a monitor, you need irrigation. We need a nurse dedicated to talk to the patient because I do under local anesthesia, so patients will be awake. So they need a person to talk to deviate their mind. This is the full system, which consists of 2.9 millimeter cystoscope set. It's a 0-degree cystoscope, so you are seeing everything end on, and there is a 20 French sheath, as I said, and we got the visual operator in case if you want to just do the inspection part of it. And we need some graspers in the unfortunate event where you need to remove an implant. So these are all the studies. We got the age-old L.I.F.T study reaching now 8th year, and we have crossover studies and we have local studies which is on local anesthesia, which showed consistent improvement in 2 years and also at 1 year. And thank you very much. I will stop briefly here, and if there is any questions in UroLift related procedure selection, I can answer that before I go through the other energy sources. You are mute, Professor.
Am I audible?
Yeah, I can hear you now.
Yes, sir.
Yeah, thank you.
Okay, great. Thank you. So thank you very much. And that's a very nice demonstration of technique indication. And we have a few questions. So there's one question from Ahmed Bashir, and he wants to know if there is any bleeding during initial instrumentation. Is there any way of doing some form of coagulation or hemostasis so that your view is clear when you shoot the implants?
Yeah, that's a very important question. We need a very, very good vision. As I said, it is not just positioning, angling, and deployment. Before the deployment in the blue thread, we should be able to see that white line. The white line is the sign that the UroLift implant is absolutely 90 degrees and it is kept, the thread is PET suture is kept taut. Only if the PET suture is kept taut, once you release the urethral end piece and cut the thread, you will get a very good compression. So vision is very, very important. We are all quite sleek surgeons, especially after the endoscopic surgeries and laparoscopies and robotics. We have become very sleek, so there is no need for real coagulation separately unless if the patient had some bleeding veins, and if there is no good vision, you need to stop. You can take like a TURP, a rollerball, or you can use a bug-bear electrode to clear the bleeder. But in general, I never required to open any energy source before deployment. During deployment, sometimes if there is an obvious vessel in the mucosa, we will try to avoid the vessel, but sometimes there won't be any vessel in the mucosa, but once you deploy, you may have a gush of bleeding because there may be a vessel below or next to the capsule, etc. But once you finish the complete deployment, as I said, the urethral component and the capsular component will compress, and then that creates a good hemostasis. And stop placing catheters. If there is a minimal bleeding like the videos what I showed, there is no need for a catheter. Patient will be able to pass urine well. The chances of somebody having a significant clots requiring catheter or irrigation or overnight stay is extremely rare.
Okay. What about, because it is done in the local anesthetic, so I think a good choice for those who are not eligible for major regional or general anesthesia. And particularly in this age, there are a lot of people who are on anticoagulants.
Yeah.
So can you use this procedure for clopidogrel patient? Obviously, S-card is something which is not an issue, but what about those who are on clopidogrel?
Yeah, doing under local anesthesia, Professor, as you mentioned, it's a very big boon. I am getting referral from left, right, and center for patients who are not fit for anesthesia, not fit for even regional anesthesia. We presented kind of a semi-live surgery in World Congress of Endourology last year, where there was a Filipino patient with spinal kyphoscoliosis. So regional anesthesia is not possible. It's too short and short neck. So GA is not safe, and we have successfully done the whole UroLift under local anesthesia. Regarding the anticoagulation policy like TURP or HOLEP or any surgeries, it is always advisable to stop the anticoagulants adequately. Say for example, clopidogrel means 5 days. If it is newer drugs like apixaban, rivaroxaban means like 48 hours, etc. But in the rare situation where the cardiologist felt that this patient had a metallic heart valve and can't stop the anticoagulants for maybe like 12 months, something like that, you can do the procedure. Especially I've done few under rivaroxaban, but you need to be a little bit more careful because a small scratch or a vessel can cause significant bleeding. Aspirin, no problem. 75 milligrams, 150 milligrams, aspirin is no issue at all. So if the patient is on any anticoagulations other than the antiplatelets aspirin, we will try to stop as normal. And in case if that patient is not fit for stopping, patient needs to be on anticoagulant, you can stop the medicine and start him on 150 milligram aspirin. Even if that is not enough, then we can give bridging heparin, a low molecular weight heparin. For example, if the patient is having the surgery in the morning list, he can have the last dose maybe like 10 o'clock or 12 o'clock the previous night. So after the procedure, patient can have clopidogrel, rivaroxaban, apixaban, any anticoagulant on the same day evening. We can restart, including warfarin, as long as the urine is staying clear.
Okay, there's another question by Shabir. He wants to know, it's a permanent implant. Can it be removed in any ways if it is for indicated inaccurate deployment or extrusion into the prostate or bladder? So can it be removed?
Yeah, it is a permanent implant, and if it is appropriately placed, as I said, if it is kept in the prostatic urethra, adequate compression and nicely placed, as you can see that the implant will get completely submerged in the mucosa. Especially if you do a flexible cystoscopy after maybe like even 1 month or 6 weeks, the whole mucosa will grow over the stainless steel urethral implant. You will see only the dimples in the prostatic urethra, and the cavity will be nicely opened up and nice cavity will be formed. But if the patient unfortunately had inappropriate placement, say for example the urethral tab is hanging in the bladder neck or unfortunately into the bladder, it has to be removed. Easiest way is by using a biopsy forceps or any like a two-prong forceps. There is no need for anything like a basket. And if the whole implant, the urethral tab and also the capsular tab, everything is there, the easiest way is just hold it and then you can pull it away because everything is inside. But if the easiest way is you can just take it into the bladder and then take it all together. But if the capsular tab is nicely implanted, the problem is only the urethral tab. As you can see, the urethral tab is just like a cloth peg which we use for the clothes. So the peg suture will be there, the cloth peg will be like this. So from your end, if you are able to hold the joint segment of the urethral tab and you need to pull towards you, it releases the suture so that the suture will get completely submerged into the prostate, which will not cause any problem, and you can remove the stainless steel urethral tab. So if it's only stainless steel urethral tab, hold the junction and pull towards you. If the whole implant is in the bladder neck, hold it and then push into the bladder so that you have enough cavity to go and then take the tab out outside. I've done easily 300 to 350 patients. I think I have removed the implant only once. And so, if appropriate precaution is taken, it is a very, very, very rare occurrence. The implants are costly, so it's better not to waste the implant also.
Great. I think you have demonstrated the technique, but still people are uncertain about median lobe. So Halimullah is asking that how would you know that your sutures are appropriately placed? If
Yeah.
the implant is appropriately placed.
Yeah, there are like major guidelines. Number one, the median lobe should not be more than 1 centimeter. If the median lobe is more than 1 centimeter protrusion into the bladder neck, it's not the correct procedure. We need to think about something like TURP, if not like holmium enucleation or any enucleation procedure. There is no doubt in that. And then the main aim is to, as I showed, we need to move the median lobe into the prostate and then select which part of the groove is more nicely and deep. And then if the left side is nice and deep, press the median lobe and then make the implants. And otherwise the implant, the firing and the safety of the white line, everything is just like a lateral lobe. Just how are you doing in the lateral lobe, the same thing you're going to do in the median lobe. The implants will go only in the horizontal plane wherever you are, and you can see that opening and the cavity straight away in your eyes. The easiest advice what I say is, you need to fire the implant as much into the prostatic urethra for safety. Even few millimeters inside the implant can become exposed to the bladder neck. So the only way you know that is, you need to remove the UroLift device into the prostatic urethra by compressing the median lobe. At one point the median lobe will try to escape your UroLift cystoscopy. At that point you know, okay, that is the break point. And then next time when you compress, you know that after 1 millimeter the median lobe is going to escape from your cystoscope. At that point you can deploy the implant. It's a advanced technique, but we surgeons always interested to have some challenge in the life, and that's why we progressed from open surgeries to laparoscopy to robotic, etc. So I will say, once you have done maybe 15 to 20 patients of simple lateral lobe UroLifts, then you will be having a good muscle memory of firing and adequate control on the implant delivery system. Then you can start doing the median lobe. It is doable. The MedLift study is a very good example. MedLift study in fact showed that the improvement in the IPSS and quality of life is much better than the lift study, which got only the lateral lobe patients. The reason is, in median lobe you create much more deobstruction, so patient's outcome will be much better. So patient selection and technique, again the same two rules for UroLift.
Okay, there